Hi, everybody. Uh, Thank you so much for joining. I really do appreciate it. I know one or two people are having a bit of a problem. They seem to be uh, connected and they're coming out. I'm not sure whether it's a problem with Zoom itself or any or, or if the problem is from our side or from their side. But if you're having a bit of a problem or you're getting kicked out, just join back in and I'll admit you back in. It's not a problem. So thanks to all of you. I appreciate it. Again, like I said, we say basic ECG, but what we mean is essential ECGs for people to know. And today is quite an interesting one. And listen, as I always say, you're always welcome at any point just to stop me, ask questions in the chat, whether it's on audio or whatever it may be, and we'll try and go ahead. I hope you'll had a chance to actually see the ECG that I put up on the group, but let's have a look at it now. And then we'll try and break it down as well. My apologies if you hear any loud noises in the back. That would be my youngest. He's always quite interested in what's going on, and you might hear him asking some questions just now. You want to say hello to everybody? Say hello, everybody.
Daddy.
Say, my name is Zaki.
My name is Zaki.
Okay. Okay, so that's Zaki for you. And
Hello, Zaki.
they're saying hello back. You say hello, everybody, not hello, Zaki. Okay. I think Zaki's had his fun now, so he'll probably go. But thanks so much. Sorry for that little interruption. So anyway, we get a patient like this, right? This is something hopefully you'll only have to face maybe once or twice a year if you're working in an emergency department. For those of you working in ICU, uh, yeah, I think you might work well at casualty, that's for sure, Dr. Sid. You keep us on our toes. But as far as the ECG goes, this is the type of thing that, you might see very often in an ICU setting, but we do see in emergency departments as well. And for those of you who are planning to go on anesthesia, medicine, surgery, any of these specialties, when you do your ICU rotation, this will be quite an important thing for you to know. So here we have a 53-year-old man, past myocardial infarction, presenting with hypotension and acute pulmonary edema. Okay, so the first thing we need to determine is what are we looking at over here? What exactly is this? Because all that we've got is a rhythm strip. So again, we're going to look at it and try and figure out what's going on just based on the rhythm strip. Now, as I told you, the first thing that we look at whenever we're looking at a rhythm strip, and we're just going to refresh our memory just so that we know. So the first thing we look at is a P wave, all right? The second thing that we look at is a PR interval, okay? The third thing that we look at is our QRS complexes. Are they narrow or wide? So that's the next thing that we look at, wide or narrow, QRS. Okay. Then we look at, does a QRS follow every P? Let me just get that there. QRS following P. And the last thing that we look at is it regular or irregular? All right. So the first thing that we can notice over here is that there's no P wave when we have a look. Now, all that we can see actually are QRS complexes. That's it. We don't see anything else. So we can't say anything about a PR interval. And we can't say whether a QRS follows every P because there's no no P wave in the first place. In other words, we can't say for sure that there's atrial activity or not. And for those of you who've joined me before, we did one on AFib and we did one on SVT. And what we noticed was something very similar. We didn't have P waves and we had a similar appearance. The only thing that we can talk about is the regularity and whether we have wide or narrow QRS complexes. So what we notice is that we have very wide QRS complexes. And whenever you have wide QRS complexes, as a general rule, this means that the atrium has no input into the ventricle. So in other words, the AV node is functioning on its own. The AV node is now your pacemaker, no longer your SA node. So, and of course, we can see that it's quite regular as well. All right. So a tachycardia, which this obviously is, the rate of this is just about, let's work it out exactly. So we're getting up to close to about 170. So a tachycardia that's coming from the ventricle, because it's a wide complex tachycardia. Does anybody want to take a wild guess as to what type of tachycardia we're looking at? You can just put it up on the chat if you want. You don't have to speak it out. Or if you want to, you can just let us know. So like I say, it's a wide complex tachycardia, meaning it's coming from the ventricle. So like I say, any guesses as to what we're looking at here? Ventricular tachycardia. Very good. All right. So that's excellent. Okay. So now we see the differences between a supraventricular tachycardia and a ventricular tachycardia. And for those of you who have been following, yes, monomorphic, very good, Nimetle. You can put it as that as well. That's a much more accurate way of putting it. Monomorphic ventricular tachycardia instead of polymorphic, which we can get to, at some point. I would like to show you guys that as well. But for right now, we're just going to concentrate on that. So monomorphic ventricular tachycardia, monomorphic meaning, of course, that it's every single QRS complex looks exactly the same. So the difference that we see between an SVT or a supraventricular tachycardia and a ventricular tachycardia is essentially this, is the width of the QRS complex. And I must be honest, ventricular tachycardias are quite tricky, and ventricular tachycardias can be very fast as well. So with supraventricular tachycardias, we get patients going up to about the 180s, 190s. With VTACs, they can go up to the 200s, 220s. I've even seen a 250 on a patient. So you've got this patient with this extremely high load on a heart that's already been damaged. And with what that's going to do is that's going to lead that patient to have more and more complications. So you have to try and bring the patient under control very quickly. All right. Now, there's a few things when it comes to tachycardias, and I'm going to discuss it here, and we're going to get to it a little bit later as well. So there's danger signs that we need to look out for, right? So the first danger sign that we look for is ischemic pain. All right. So if your patient has ischemic pain. The second thing is the level of consciousness. All right. So the patient has a decreased level of consciousness. Then, of course, we look for any signs of heart failure. We look for signs of shock. All right. So this may be poor cap refill, whatever it may be. And all of it at the end of the day is tied back to one thing that you can quickly pick up in the emergency department: hypotension. Hypotension leads to all of these. Okay. The fact that your BP is low and your heart rate is high, you remember your heart receives its blood supply during the diastolic phase. It can no longer receive it. So you start receiving less blood. So you start getting ischemic pain. There's less blood supply going up to the head, up to the brain. So you start getting a decreased level of consciousness. Your heart is unable to pump correctly, you start going into heart failure, and due to hypotension, you go into shock as well. But hypotension is the first thing that you will see, and it's the first thing to know to tell you whether this is stable or unstable. Okay. So in other words, what we have here is we have a patient with an unstable ventricular tachycardia. Okay. So any idea on what we should do? If anybody wants to take a guess, this is now your patient. They've now come in. All right. So while we're just looking at the answer, I want you guys just to think about it, what you would like to do. Okay. Cardioversion. Very good. Very good. Any particular type of cardioversion that you want to do? Are you looking at chemical or are you looking at electrical cardioconversion? But that's the correct answer. That's where we're going to. So let's have a look at our answer, but very good there. Very good answer. So as it's put here, it's not a probable, it is a ventricular tachycardia, a rate of 170. And the differential diagnosis of a regular wide QRS complex tachy includes supraventricular tachycardias with aberrant conduction, which we don't have in this case, SVT or atrial flutter with aberrant and VT. So these, what they are talking about is, in other words, you're getting supraventricular tachycardia or sinus tachycardia with an underlying bundle branch block, which have a particular look to them. And I don't want to confuse you guys, so I'm not going to go into that right now. But suffice to say, and when I used to teach in the department before, we used to have the nice computer and things like that. I used to always describe this as vampire's teeth. So whether you see upside down vampire's teeth or vampire's teeth as they are here, that's a ventricular tachycardia until proven otherwise. And 95% of the time it will be that, and 5% of the time it will be these others. So as soon as you see that, wide complex, regular, it's a ventricular tachycardia, all right? So without any clinical information, it's estimated that 80% of these rhythms, greater than 80, but it's meant to say 95 as the latest, is a VT, all right? And given the additional information of the patient's age, past MI hypertension, and acute pulmonary edema, it's almost definitely a VTAC, all right? So we have a ventricular tachycardia. We know that we need to rush, we need to cardiovert. So what are you going to try and do as that emergency doctor in that ICU, even in theater or in the A&E, whatever it may be? Are you going to run for your defib, or are you going to run to your medical cupboard? What do you think? What would you prefer to do? Any ideas? Listen, it's a 50-50 chance of being right, and I won't say who answers what. So that's the thing. Medical, not a bad idea. What could be the problem with going for medical, though? Might take a bit of time. That's the thing. All right. Well, anyway, we're going to get to that now. Let's just look at the signs and symptoms. Yeah, well, when I say that, what we'll get into it now. I'm going to explain to you guys what I mean by there might be a slight delay. You're not wrong in saying medical. Don't stress. I'm just and you're not 100% right if you said electrical either. So don't worry. It was a bit of a trick question. But anyway, so this is just to explain the signs and the symptoms. So patients generally have a fast heartbeat or fluttering feeling in the chest, palpitations, and then dizziness, lightheadedness, chest pain, neck tightness, shortness of breath, fainting, and eventually cardiac arrest. So this is just the flow that patients follow as they are getting more and more hypotensive and as the tachycardia worsens, okay? So it's just something to know. So your first stage being palpitations, then of course your CNS symptoms, and then from there you start getting symptoms of cardiac ischemia, and then you start going into failure, and eventually there's probably no blood supply going to the CNS at all, and that's how they end up over there. Okay, so like I said, these are the 5 times that you need to be worried. Hypotension being number 1, cardiac failure, ischemic chest pain, decreased level of consciousness, and acute signs of shock, which also includes hypotension. But even if you just remember hypotension, it's very unlikely a patient will have a tachycardia and being cardiac failure, but with normal BPs. I'm not saying it's impossible, but it's highly improbable. Or have ischemic chest pain, but nevertheless still have normal BPs, okay? So I just wanted to try and get into this, all right? So let's go into what we were talking about. So we attempt to identify the cause, of course, that's fine, but that's not the main thing. That's not what we're trying to get into. So this is your ACLS algorithm on how you manage these patients, all right? So you maintain oxygen saturation. How do you determine it's unstable? Again, hypotension, decreased level of consciousness, signs of shock, and chest pain. So if your patient is stable, now remember, you guys, somebody put down medical for unstable, right? So it's you establish an IV intraosseous access, and you consider giving 6 milligrams bolus of adenosine, and then you may go on to amiodarone, and then an antiarrhythmic infusion. So that's why I say you're not 100% wrong in that you can actually start with this depending on how bad the instability or how unstable the patient is. So let's say, for example, your patient has a BP of 100/75. Their maps are sitting somewhere in the 80s, but technically they are hypotensive. They don't have ischemic pain. They don't have any, evidence of failure and things like that. This would be the way to go. You would consider starting here. One of the main problems that I'm sure if you guys have been following is that adenosine is very difficult to give. And if you don't give adenosine properly, it very rarely works. So I actually don't, I'm not a big fan of adenosine because I've never really seen it work properly, even when given exactly as it's supposed to be given, So it's called the two thumbs method. You need to have a three-way tap. You need to have two people to be able to give it correctly. And to be dead honest, it's a lot of work and it really doesn't work most of the time. So most people actually go for an amiodarone infusion, which we've discussed before. 150 milligrams in about 200 ml of fluid running over about 10 minutes. But let's take our patient that we had. So our patient had signs of heart failure, plus hypotensive, plus a previous infarct. So in his case, you would probably run for synchronized or electrical cardioversion. I hope everybody understands what I'm trying to say. If it doesn't make sense, please tell me now, because it's an important thing to be able to differentiate when you're there on the floor, So in other words, you have to decide. And if you have made that decision, you must decide why you're going through with it, all right? So there's a lot of things that you have to take into consideration. So for example, if the patient's had a recent MI, a cardioversion could easily increase the amount of cardiac damage. If your patient is relatively stable, do you start with medical cardioversion first? Does the patient have repetitive, attacks of tachycardia? In which case, are you going to keep on, giving them, are you going to keep on shocking them? So these are the things that you need to think about. But if we think about our particular patient that we have here, 53 years old, I think, if I remember correctly, previous MI, now with hypotension and signs of acute failure. He's the type of patient that we'd rush to get the defib on. We'd consider him as quite unstable because he's got two signs of instability. I hope that makes a bit of sense. And I hope you understand why I said you guys are the person who answered medical is right in a way, but why we, in this particular case, we would go for synchronized cardioversion. So I hope you guys get that. If you can give me like a thumbs up or let me know if I need to explain more. Okay, so it's understandable. Okay. So let's say, for instance, you decided to go this route. Okay. And while you're going that route, you realize, okay, listen, maybe I've made a mistake. It's never a problem to jump across. And that's very often what happens in a resus situation, no matter where you are. Sometimes you may already have the defib set up, and then you realize, okay, wait, just hold on. Let me just give this a try. There's absolutely no problem with that, just so long as you can justify it. However, in these types of scenarios where we've got hypotheticals, let's put it that way, these are not maybe real patients and things like that, and where you've got to follow things as they should be, then we go into synchronized cardioversion. Now, I did put up a video about synchronized cardioversion and how it works. I hope that you guys had a look at it. Now, here's cardioversion and how it should work. So if you have an SVT, or let's just keep it as an SVT for now. You can start at 50 and go up to 100, sometimes 120 if you really need to. QRSs that are narrow and irregular. So we're talking about atrial fibrillation. And this we had discussed previously about when we need to control the rate and when we need to do, worry about coagulation. So that's where you'll start off there. Now, this is our patient. The QRS is wide and regular. So you're going to cardiovert at 100 joules. Okay. If the QRS is wide and irregular, you don't do synchronized. You just defibrillate, okay? Now, the other thing that I have to point out here is we're talking about a patient with a pulse. Pulseless VTAC is something else completely, okay? So the one thing I can tell you from all three of these, if you notice, 100 joules is kind of the place that you would be safest. So if you can't remember which one needs 50, which one needs 120, which one needs this, if you go at 100, you should be okay. All right. Now, ideally, wherever you are working, please keep a chart or keep something over there that at least allows you to know what, or even on your defib itself, how much you should be giving. So I hope that would help. So let's just go through it just one more time, just for the sake of us being 100% on what we're talking about. So we have a patient who comes in with a ventricular tachycardia that we've established because he's got wide, regular, monomorphic QRS complexes. We know that this patient has an unstable tachycardia because of the hypotension and acute pulmonary edema. We've seen that already. And if we look at this, he's probably at this stage. So he's quite close to a cardiac arrest as well in terms of instability. And he's got two signs of instability. Patients may have combinations, they may only have one, but even if you just see the hypotension, you should be already worried. So it would make us think that we need to go to synchronized cardioversion. Now, when you do synchronized cardioversion, the one thing I just want to advise you guys, we all have that idea of, you press the pedals and it immediately just, delivers the shock. One of the things that happens with synchronized cardioversion is because it's waiting to shock on the R wave, at peak contraction, it may sometimes wait. So you may sometimes even miss a beat and then it goes. So don't just press and release. You've got to keep your paddles pressed down. Okay. So you can use amiodarone as well. This is something, if you want, you can take a screenshot of it. But basically, what amiodarone does is amiodarone just basically prolongs the action potential. Basically, it starts separating the T wave from the QRS complex. And it works very well in VTs and SVTs and things like that. The one way to imagine why ventricular tachycardias happen, I'm not sure if any of you have ever been walking and your one shoe, your one leg catches the back of your other leg and you do that little stumble. Where you kind of just walk and then you regain your balance. But that little stumble that you take of those few steps, that's essentially what's happening with ventricular tachycardias and SVT and supraventricular tachycardias. It's something that we call an R on T phenomenon. Now, if you have a chance, go and read it up. It's quite a nice thing to know about. And you sound very smart in your ward rounds as well. But essentially what happens is that you get this thing happening where the heart tries to contract and relax at the same time. So it stumbles upon itself and then it keeps on stumbling. So there's no end to that. So if you can imagine that little stumble that you take, but then you correct yourself. Now imagine that stumble just continuing. That's essentially what a VTAC is. And so what amiodarone does, if you decide to give it in a stable patient, is that it basically separates the 2 feet. It separates them so that the one can get a landing and allow the other one to go again. All right. And generally what you would do is that you would give 150 milligrams IV over about 10 minutes, followed by a continuous infusion. Now, the continuous infusion does depend on in the protocols at your own hospital where you're working. But generally, it's about 150 milligrams in 200 mils is between 5 to 10 mils an hour. That's how it runs. Now, it can also be given as a bolus in cases of cardiac arrest due to VT and VF, 300 milligram IV push. I must be honest, in most of the cardiac arrest due to this, the defib itself has been sufficient, but I have used it a few times like this, and it does make a difference. So it is something that you can think about. Although I must be honest, in most of those situations, I've even forgotten to give it because you tend to, overlook it in the case of cardiac arrest, but it can be used. Okay, the very rapid onset of action does have some adverse side effects that you need to worry about, especially as you start going up in dosages as well, right? And especially if the patient's going to be on it for a few days. So especially for those of you who are going to do ICU and ICU rotations, it's quite important to know that you're going to get pulmonary and liver and thyroid dysfunction. So you can't just give it willy-nilly. You need to know exactly what you're doing, right? So how do you do synchronized cardioversion? So you turn the machine on, first thing. Right. I know a lot of people, but that is the first thing that you do. You make sure that you are in sync mode. So it will often indicate it, and you'll see these little dots, or you'll see something on top that will give you an indication that it's now a synchronized. You're in the sync phase, if I can put it that way. So a small square or something should appear over there. You place pedals. You start at 100 joules if not sure. You can start at 150 in an adult and escalate to 200 joules as needed. And in children, it's 4 joules per kilogram. That's how you remember it for kids. So you have to sort of use whatever weight system you are using, be it a Broslow tape, be it guesstimate, patient info, however it may be, that's what will tell you. And then you work it out from there. And this is just how you apply pads, the patches, and just how you attach paddles. It's just showing you that over there. So there's a good video to watch, which I'm going to put on as well so that you guys can see. Uh, yeah, and that's basically the end of that. So I'm not sure if you guys have any questions or anything that you guys would like to know. So this is also actually, it's a nice example of a VTech, despite it being a joke, but it actually is quite a good example. So I'm not sure if you guys would like to revise or look at anything else, but VTech is one of those ECG rhythms that is very scary when you see it. And it can present in very, uh, how do I explain, in very extreme fashion. So for example, I've seen VTACs where, I'm just going to try and draw this. And I remember this was when I was first starting off, and it was quite scary for me in that the patient had a VTAC that kind of looked like this, so you had these huge wide QRS complexes that were going down, and it was in nearly every lead. And I myself got a tachycardia based on that, So, it's one of those that can present in a very wild fashion. And if you can keep your wits about you, it's quite easy to sort out, as you can see, because all you're going to do is just to synchronize cardioversion or chemical cardioversion. That's about it. Oh, and one caveat to that as well, which was not necessarily covered in the algorithm, is that once you get the patient back, even in synchronized cardioversion, you should put the patient on an antiarrhythmic infusion as well. I'm going to put this link up on the um, group as well so that you guys can have a look. But I'm not sure if there's any questions or anything that anybody would like to know. Pulseless VTAC is considered cardiac arrest. So if you see this without a pulse, you consider it cardiac arrest. You immediately go to defibrillate the patient. All right. Does anybody else know the other rhythm that you have to shock? Because there's only two shockable rhythms. Just as a by the way, I'm not sure if anybody knows the two. One of them is pulseless VTAC, and I'm sure you've got one or two people maybe who've been through ICU or have maybe seen it. Okay, but not a problem. If you're not sure, it's ventricular fibrillation. All right. So VFib and VTAC are the two that you shock, and asystole and pulseless electrical activity are the two that you don't shock. So, if there's a playlist I've got as well, just showing resus and how you do it. But any questions at this stage? We've still got a few minutes before Zoom cuts us off. Or if everybody's happy, my apologies as well for Monday that I couldn't um, have the session. And my apologies if I'm slurring a little bit. And I'm actually on some quite heavy medication at the moment, but I didn't want to yeah, I don't want to cancel again. So my apologies if my delivery is not as fast as usual. And if everybody's happy, we can just end it as well. That's no problem. If you can give me an indication on the chat, then we can take it from there. So I'll wait for you guys now to let me know. Okay. Okay, thank you. Thank you, Doc. I appreciate that. I just hope you guys understand it. And hopefully I've got some good ones lined up that are coming up as well, specifically on things like bradycardia and things like that, and looking at other types of infarcts, which are things that we see quite often. So hopefully you guys enjoy those as well. Thank you so much, Doc, for that on the chat as well. And hopefully on Saturday we'll have a nice one. I actually want to show you guys about the laryngeal mask airways and how you use that and how you place them. So I hope you guys will join me again on Saturday for that. But otherwise, please keep well and enjoy the rest of your evening. And thank you so much for joining me. I know how difficult it is to give up your evening, even for the short time. So I really do appreciate it. So all of you, please keep well. And hopefully I'll see you all on Saturday as well. Okay, bye. Thanks a lot. Where can we watch more videos? I've got it on the YouTube channel, which is ER Mentorship Hub. Let me just try and get it up here for you, and then I'll do the share, and then you can see it. Just 1 second. So I just have to open my YouTube page, but it's got all the kiddies stuff on it. So the Bluey and all the stuff that they enjoy watching is all showing up. So let me just show it to you there. So there you go. That's where it is, the ER Mentorship Hub. Okay. So that's the name of it, right? ER Mentorship Hub. If you search that up, and appreciate it if you guys do subscribe. As you can see, we've got 160 subscribers. So another 3 or 4, and I'll be competing with Mr. Beast and Meat Canyon and all these guys who've got a few more subscribers than me. But but I appreciate everybody who has subscribed. And all the playlists are there as well. So you can have a look. So I've got all of them set out over there. There's some of them, of course, that are unlisted. They're just private and that, but these are generally the places where you'll find all the videos. So I hope that answers the question. And again, thanks so much for watching, everybody. And I'll put this up on the group as well, and I'll put in that link as well to the video on synchronized cardioversion. All right, but keep well, and hopefully I'll see you guys again soon. Okay, bye.